our conditioning regimens. And what I will try to show you is that the interaction between our immunology group and the pharmacology group has been very, very important in this perspective. So, very simplistic, of course. Before you can administer donor stem cells to a patient, usually, except from those rare skid cases, but usually you have to give conditioning to the patient to get proper replacement of the patient's stem cells by donor stem cells to have proper long-term graft function. And what I will try to show you in the next couple of slides is that anti-T cell antibodies, anti-lymphocyte antibodies to be more specifically, play an important role in the preparation of these patients. And I will show you that a better understanding of these medications, how they behave in the patients, is very important to understand immune reconstitution. It's very important to optimize the treatment, and is also very important, especially in malignant diseases, but maybe also in non-malignant diseases, to deal with additional cell therapies early post-transplant. So ATG, I think most of the parents and patients still find it quite kind of strange that we administer drugs that have been raised in rabbits, but that's what we're actually doing in 2017. So we infuse antibodies that have been raised in rabbits, or maybe even in horses, but mainly in rabbits. And what is, I think, important to realize, and I'll come back to that at the end of my presentation, is you have different ATG products, and they are being generated in different ways. If I understood well, over here in your institute and in ours as well, mainly Genzyme ATG is being used, and this product is being generated by immunizing rabbits with human thymus tissue, bulk tissue. Not with T cells, not with thymocytes, with bulk thymus tissue. So obviously this rabbit will generate a lot of antibodies against everything which is expressed in a thymus. So it's really a polyclonal drug. The drug is being purified by the pharma companies, so you end up with a purified IgG product which contains all kinds of reactivities, mainly rabbit antibodies, which contains as a minor fraction antibodies directed against human thymus tissue. Another product, previously assigned Fresenius and now more recently being taken over by another company, and now it's called Graphlon, is being generated in a completely different way by immunizing mice with Jurkat T cells. So with a T cell line. But again, a T cell line does not only express CD3, it also expresses a lot of other antigens, and also antigens that are not expressed on T cells only. So it's a big misinterpretation that a lot of people think that ATG is anti-T cell. Yes, it is, but it is much more than that. It reacts to a lot of other cell types, immune cells in our body. And both drugs are being used in parallel. So depending on the country or the institute where you are visiting, people use either Genzyme or Fresenius ATG. And if you look at transplant protocols, or you look at the EBMT guidelines, you will find you can use both. If you use Genzyme, you use dose X, and if you use Fresenius, you use dose X times 4, because that is what people think is about the difference in activity between the two drugs. It's not very scientific, but that's the way it's being dealt with. So then you end up with these different dosages, about 6 to 8 milligrams, sometimes 10 is usual for Genzyme ATG, and somewhere in between 15 and 30 milligrams per kg is usual for this medication. If you compare this with the subtle and the strictness how we calculate some other drugs that we administer, this is kind of a very crude approach of dealing with this very important medication. In addition to ATG, Campat, an anti-CD52 antibody, is quite often used. At least we use this as well for certain topics. This is a more elegant antibody because it's a humanized antibody. You do not have to immunize rabbits. But they are different from a biological perspective because the half-life of ATG is completely different compared to the half-life of alemtuzumab, whereas in previous clinical protocols, they were quite often kind of used in a similar way, being administered at the same time point, being used in standard dosage. So altogether, this indicates that there is probably much more to learn and to optimize in the treatment with these drugs than we did in the past. And again, as I already mentioned, bear in mind that these antibodies do not only recognize T cells. In this slide, you see put together a lot of patients. Each dot is one patient at these different time points post-transplant. The blue line are the assembled patients being transplanted with a matched sibling donor. None of them has received ATG or Campat. And you can see that the CD4 reconstitution as a measure of immune reconstitution is variable, but quite close to each other. This is a logarithmic scale. So, however, if you use a matched unrelated donor or a mismatched unrelated or haploidentical donor that all received ATG, you see two important things. One, you already know, that the T cell reconstitution in those patients is delayed compared to those patients that did not receive ATG. But what you also see is an enormous inter-individual variation in the time needed to recover CD4 counts. On paper, these patients have all received, almost all received, the same ATG dose, a certain amounts of milligram per kilogram body weight. So on paper, you think you've treated them in the same way. In practice, immune reconstitution is completely different. So what we started to do already quite some years ago is to study ATG pharmacology, pharmacokinetics. And what we did is we measured using an ELISA assay, a FACS assay, in which we measured the amount of ATG antibodies circulating in the patient with respect to their binding capacity to a standard T cell line as a measure of immune reactivity. And the take-home message for today is actually mainly on the left side. So what you can see here is the days in which ATG was administered. So you see an increasing concentration in the blood of ATG. This is total ATG, so total rabbit antibodies. Not T cell binding antibodies, rabbit antibodies in a human circulation. And in time, they decrease. And some patients decrease like this, and others decrease like this, and this is the mean. If you measure in these patients the amount of antibodies, rabbit antibodies, with active binding potential against T cells, you again see a huge variation, how these antibodies decline, and this is the median. And what happens in practice? This is just one example, Two patients with beta thalassemia being treated, I mean similar conditioning regimen. They received both 10 milligram per kilogram body weight ATG, and in this patient you can see a high level of ATG as top level and a very slow decline in the circulation, whereas this patient had a much lower peak level and the ATG was already hardly detectable within the first week post-transplant. This must have an implication for these patients because we give the ATG for two reasons: to prevent rejection and we think to prevent graft-versus-host disease. The same thing for Campat, for alemtuzumab. Each curve is a patient. They all received the same dosage, 1 milligram per kilogram body weight. And you can see that some patients have hardly any T-cell depleting antibodies in the first week post-transplant, whereas others still have antibodies hanging around 5 weeks post-transplant. This must have an impact. And it does. So when you look at the myeloid engraftment, neutrophil engraftment, you can see that patients with ATG, of course they vary, as we know, in the timing of myeloid engraftment, but the variation is much bigger if you look at the T-cell reconstitution in those patients. The same thing for CAMPAT. There is, of course, variation in the neutrophil engraftment. Some are faster than others, but there's a huge variation in the timing of T-cell reconstitution in those patients. And what we then did for most of our analysis is to calculate the exposure of ATG before the graft was being infused, bearing in mind that we mainly administered it at this moment, at least that's what we thought, to prevent rejection, so to kill the autologous T cells, and the exposure of the antibody post-transplant. And we thought that had mainly to do with controlling the alloreactive T cells. And what we observed is that especially in older children, there was a huge exposure post-transplant. And what we also learned is that a low level of lymphocytes at the moment that you start administering ATG, so in the pre-transplant period, results in a higher exposure post-transplant. So if you have less target cells in the pre-transplant period, there is more ATG left to persist post-transplant. And this is one of the papers that we published on this in Lancet Hematology, where we put together the patient cohort from Leyden and the patient cohort from our colleagues in Utrecht. We do a lot of these studies together, which is very, very useful and very effective to get a large number of patients and a good analysis. A heterogeneous cohort of diseases, different graft sources. And these are some of the main take-home messages, I think. So this is when we calculated the impact of the exposure before infusion of the graft. So the pre-transplant exposure, mainly directed against the recipient immune cells. And what we observed is if you have a low exposure of ATG in the pre-transplant period, those patients are much more at risk to develop severe graft-versus-host disease. And that's interesting because that we didn't necessarily expect this. So apparently, immunodepletion of the host has an impact on the occurrence of graft-versus-host disease post-transplant. And we think that this has to do with the efficacy of depletion of antigen-presenting recipient cells pre-transplant. And it also has an impact on chronic graft-versus-host disease. In the post-transplant period, we observed that if you have a high exposure of ATG, that your outcome, both in cord blood transplantation but also in bone marrow transplantation, is inferior compared to the ones that have a lower exposure post-transplant. And the lower exposure post-transplant has a beneficial effect on the immune reconstitution, and I'll show a few slides on this later on. It also has a positive impact on relapse of malignant diseases, and probably because you have more potential for a graft versus leukemia effect if you have not a very persistent presence of immunosuppressive antibodies over here. I'll skip this because of time. So based on all these observations, realizing that there are huge differences between individuals with respect to the biological efficacy of the drugs that you administer, we have now a more or less individualized approach where we take into consideration the body weight of the patient. The higher the body weight, the lower the doses per kilogram body weight that we administer. And we take into consideration the number of lymphocytes before we administer the ATG. So if the patient has a high level of lymphocytes before you start the conditioning, we give more ATG. If the patient has very low levels of lymphocytes, we give less ATG. So this is what we do in all patients. There are also some very individual approaches that I would like to share with you. This is a patient in which measuring antibodies, in this case it was CAMPAT, really helped us in managing this individual patient. So the red line is the patient. This is the decline of the CAMPAT antibodies in the circulation. And this patient developed adenovirus viremia and also with clinical disease phenomena. And we administered cidofovir to try to control the disease, but it was not very effective, as you can see here in the adenovirus load in black. We have the opportunity in our institute to administer virus-specific cells, so adenovirus-specific T cells, cells isolated from the donor and being infused into the patient. But if the same patient still has a lot of circulating antibodies hanging around, then this beautiful virus-specific T cells, as soon as you administer them, they are being killed by the CAMPAT antibodies. So what we did in this case, we first performed a plasmapheresis in this patient based on these results to get rid of the circulating CAMPAT antibodies. And where the CAMPAT antibodies were really low, we infused the adenovirus-specific T cells. And as you can see, the adenovirus viremia was completely cleared. Without information about the circulating antibodies, we would not have been able to make this clinical decision. Another important thing that I would like to share with you is the following. I already explained to you that ATG is not ATG, so it depends on the type of ATG that you use, what the biological efficacy is. And what you see here in gray are the curves that I already showed, the decline in ATG antibodies in a cohort of patients being treated with Genzyme, so the drug that is also being used over here. But when we analyze patients that have been treated with Fresenius, so the other type of ATG, we notice two interesting things. One, the total antibody levels are higher compared to Genzyme. That makes sense because you give a higher doses of Fresenius rabbit antibodies than in Genzyme. But in contrast to what we expected, the concentration of active ATG, so ATG able to bind T cells, is much more rapidly declining. So from this perspective, if you use Fresenius ATG in your protocol, the immunosuppressive effect on most of the patients is much shorter compared to the situation when you use Genzyme. Another interesting thing that I would like to share with you is the following, and we didn't expect this, and that's why I would like to share it with you. With the antibodies, we infuse foreign proteins. We infuse rabbit proteins. We infuse humanized, but of course never 100% perfect human antibodies. So those are alloantigens or immunogens. And what we observed in several patients, it's a minority of the patients, but it is of clinical significance. Here you see a lot of patients that were being treated with CAMPAT, and this is decline in their concentrations. In a few patients, you see a very steep decline in the concentration of the antibodies, much steeper than you would expect. And what happened in these patients is that the patients developed antibodies against the antibodies. So anti-CAMPAT antibodies. Is that important? Yes, because those antibodies, they kind of neutralize the medical antibodies. And you can see this over here. So the anti-CAMPAT antibodies rose quite rapidly within the second week post-transplant. And in parallel, you see that there is a steep increase in donor T cells. So instead of having a protective level, let's say during the first 3 or 4 weeks, the protection by the CAMPAT antibodies was suddenly gone. And these patients developed serious graft-versus-host disease. The same thing with ATG. which are rabbit antibodies, so you might expect that the chance is even higher that they develop those antibodies. Here again, you can see the antibodies are high, and suddenly, they go, that's too, they go very rapidly down. And again, you can see here the generation of antibodies against ATG, and this patient also very rapidly afterwards developed graft versus host disease. Even more interestingly, using allotype technology to make a distinction between whether the antibodies were of donor or recipient origin, we found out that these anti-ATG antibodies were produced by donor B cells. That sounds incredible, and we didn't expect that. So apparently it's such a strong immunogen that it's possible to generate donor-derived antibodies already in the first 2 weeks post-transplant. So this is the pharmacokinetics. So I hope I've convinced you that measuring these antibodies can really help you to understand what is happening in your patients and to go to a more individualized approach to understand their problems. What is the impact on immune reconstitution? I will show this in a few slides. So when we analyzed the immune reconstitution in patients being treated with ATG, we realized that as long as the patients have this level of circulating ATG antibodies, which is arbitrary units per milliliter, you will never find a single T cell. So this is really protecting T cells from reconstitution. And for alemtuzumab, for Campat, it's a different concentration, but there's also a threshold to be defined. If you measure in your patient this level of alemtuzumab, you will never find T cell reconstitution. However, when we analyzed other leukocyte populations, NK cells or monocytes, there was absolutely no correlation. And that's why I mentioned in one of the first slides, ATG does not only bind T cells, but it also has the potential to bind B cells, monocytes, NK cells. But apparently, if you open a vial of ATG and you take those antibodies and you do a FACS staining on your peripheral blood, ATG binds to all the different cell populations. If you take serum from the patient that has been treated with ATG, so you take serum at 1 week post-transplant or 2 weeks post-transplant, and you measure whether there is ATG, and if there is ATG, it can very actively bind to T cells and prevent thereby T cell reconstitution, but it is no longer able to bind to NK cells, and therefore the NK cells have the opportunity to reconstitute. So apparently in vivo, by kind of an absorptive mechanism, there is kind of a selective clearance of ATG reactivities to other cells than T cells. Is that important? Yes, I think it is, because at the same time where you have ATG levels or Campat levels, where there is no opportunity for T cell reconstitution, quite a number of these patients, have already reconstituting NK cells. So there is a possibility for selective immune reconstitution when there is no T cell reconstitution possible yet. And when we looked at this in more detail, we observed that the NK cells that are reconstituting at a moment when there is not yet T cell reconstitution have a very particular phenotype. Those are the so-called CD56 bright NK cells. And those NK cells those are not the cytotoxic cells, those are the cytokine producing cells. And when we analyze this in a bit more detail, and this is very much detail, I'll explain to you what we did. So what we did is we analyzed in a large cohort of patients with acute leukemia that were treated with either matched sibling donors or matched unrelated donors and having received myeloablative conditioning. We analyzed the immune reconstitution at these time points using multicolor flow cytometry, really multicolor. And what we observed is that in those patients where there is not yet T-cell reconstitution, so that is in this upper quadrant, so these are the weeks post-transplant, there are no T-cells, it's white dots. There is an enormous expansion of CD56 bright NK cells, which does not occur when there is early T-cell reconstitution. These CD56 bright cells are very activated, and this is maybe a bit of a complicated slide, but I'll tell you the take-home message. These NK cells in the early weeks post-transplant, so 3, 4, 6 weeks post-transplant, which is in the upper left, they have a very activated phenotype. They express several markers that are very indicative for an inflammatory response. They do lack immature markers. So those are mature cells, they are mature activated CD56 bright NK cells. And more importantly, in contrast to normal CD56 bright cells, which is normally a minor population in our blood, these cells had very high levels of granzyme comparable to the normal cytotoxic NK cells. And they do not only express these proteins, but they are also cytotoxic in cytotoxicity assays. And apart from their cytotoxic potential, they also maintain the potential to produce cytokines like interferon gamma and TNF alpha. So we're actually dealing with a very typical NK cell population that is only present early post-transplant and has characteristics that you would normally not expect from NK cells. And the patients that had this very early CD56 bright NK cell expansion did as good as patients with normal T-cell reconstitution with respect to overall survival, leukemia-free survival, and transplant-related mortality. So although T-cell reconstitution was delayed, it seemed that these early reconstituting NK cells kind of compensated for the lack of T-cells. Against these NK cells have features that they might migrate to inflammatory sites. They even had high expression of skin homing receptors. They lacked receptors that would bring them to the lymph nodes, and they had cytolytic properties. And interestingly, in a very recent paper by the group of Luigi Notarangelo from the NIH, he described in REC1 deficient SCID patients the characteristics of NK cells that are very, very similar to the NK cells that we observe early post-transplant. So it seems to be indeed that there is kind of a reactive of compensatory mechanism of NK cells when there are no T cells hanging around. So altogether, the ATG information and the serotherapy information that I've given hopefully convinces you that it is very important to measure these values to better understand the differences between patients and also to optimize individual treatment of our patients. But it also has major implications for post-transplant cellular therapy. For example, here in this institute, there are several protocols in which early post-transplant cellular therapy is being administered with the aim to strengthen immune reconstitution. But of course, in that context, it would be extremely valuable to be informed about the circulating ATG antibodies, because you do not want to give these therapies when there are still antibodies circulating. So in the last few slides, I will share something about the chemo conditioning part. Again, together with our colleagues in Utrecht, we are working already for quite some years on busulfan pharmacokinetics. And the take-home message for this is summarized in one slide. There is huge variation between individuals that are being treated with busulfan with respect to the in vivo exposure. So patients, again, having received on paper the same dosage, have a very different exposure and persistence of these drugs in vivo. Is that important? Yes, because if you put on the x-axis the exposure level of busulfan in those patients, and on the y-axis the risk of developing unwanted side effects, you can see that if you give too much of the busulfan, then you have a higher level of graft versus host disease and veno-occlusive disease. If you give a very low exposure of busulfan, then you might end up with graft failures or rejections. So there seems to be kind of an optimal range in which you can target the drug, busulfan. So how it works in practice, this drug is being administered over 4 consecutive days. And on the first day of administration, we take serum levels, we calculate the exposure. On paper, you should have 25% of the overall exposure in the first day. In those patients where you have an overexposure, we do dose adaptation in the second, third, and fourth day of the administration. And if you have an underexposure, you should increase and further monitor. And in this way, we are able, in all our patients, to have a very narrow therapeutic window in which we expose all patients to busulfan. But busulfan is not the nicest drug in the world. It is a very, of course, it's an alkylating agent with a lot of side effects and also long-term side effects. And like in your institutes, we are very interested in the drug treosulfan. And we've been asking ourselves the question, can we learn the same things from treosulfan as we learned from busulfan? So what we did in the last 4 or 5 years is to measure treosulfan levels and to develop the technology, which I will summarize very briefly here. But we are now in a position that we are able to measure treosulfan exposure using a very limited sampling strategy with only 2 samples after infusion, and based on that calculation we can determine the exposure to the drug. Together with the group from Franco Locatelli in Rome, we performed a study in which we analyzed almost 80 patients being treated with treosulfan regimens. So it's a mixture of diseases, a mixture of ages, donors and graft sources. And the treosulfan dose that we both used was 30 grams per square meter in patients under the age of 1 year and 42 in the age above 1 year. And this is what comes out. So on the y-axis you see the in vivo exposure to the drug, and you can see that there is a huge variation in the exposure, particularly in the very young patients. Well, so when we correlate the exposure to clinical toxicity, we observed that patients that had a high exposure much more often developed serious toxicity, in this case mucositis, compared to the ones who had lower exposure. And the same thing holds true for skin toxicity. There was also significantly more skin toxicity in patients having higher exposure to treosulfan. We did not find a correlation between the exposure and liver toxicity or neurological toxicity, but therefore we have to bear in mind that in the younger children we already administered a lower dose than maybe some other people would have performed. And we are currently in the process of analyzing in a larger cohort, in a more single disease cohort, the impact of exposure on long-term outcome, mainly in an ALL cohort and an international ALL cohort where we mainly focus on relapse risk, and in patients with thalassemia where we are currently analyzing the impact of the exposure on disease-free and transfusion-free survival. So this is where I would like to end again by acknowledging all these people, and I hope I've made clear to you that a collaboration between clinicians and people in the lab, either immunologists or pharmacologists, can be of enormous help to better understand our treatments and to improve the treatments of the children that we are dealing with. Thanks for your attention.